Intracardiac repair of modified Senning's operation medical animation 3D technology. Transposition of the great arteries (TGA) is a congenital defect of the heart in which the anatomic relationship of the great arteries is reversed. Unlike in normal positioning, the aorta arises anterior to the pulmonary artery and from the right ventricle, while the pulmonary arteries lies posterior to the aorta and arises from the left ventricle. Patients with TGA are subdivided into those with intact ventricular septum, 50%, ventricular septal defect, VSD, 25%, and VSD with pulmonary stenosis, 25%. Other frequently found cardiac anomalies include patent ductus arteriosus, PDA, coarctation of the aorta, COA. Transposition of the great vessels is the most common cyanotic heart defect in infancy and accounts for 9.9% of all cases of congenital heart disease. Normal structure of the heart and circulation of blood. Transposition of the great arteries, structure of heart after modified Senning's operation. Red dotted line indicates pulmonary venous baffle. Blue dotted line indicates systemic venous baffle. Transposition of the great arteries is characterized by two separate parallel circulations, in which the systemic venous blood passes through the right ventricle to the aorta, while the pulmonary venous blood passes through the left ventricle, resulting in cyanosis. Some mixing between the circulations is mandatory to sustain life and is dependent largely on the type of TGA. Patients with TGA and intact ventricular septum survive because of aortopulmonary flow through a patent ductus arteriosus, often enhanced by prostaglandin E1, and a left-to-right atrial shunt through a dilated patent foramen ovale caused by high left arterial pressure and an incompetent flap of the foramen ovale. This mixing, however, allows for only marginal tissue oxygenation, which is not improved with higher concentrations of inspired oxygen. Atrial balloon septostomy or surgical creation of an atrial septal defect improves systemic oxygen saturation and sets conditions for long-term survival. Redirection of blood using atrial flaps to correct patients with transposition of the great arteries, TGA, was described by a key Senning from Sweden in 1959. Later, Mustard's technique became the operation of choice in most centers. Braum and Associates introduced some modification of Senning's operation in 1977. In 1959, a key Senning from Sweden first published an ingenious technique for physiological correction of transposition of great arteries, TGA, utilizing flaps of atrial wall to interchange the venous inflows into the two ventricles. The procedure, which takes his name, became the first viable intracardial surgery for the relief of cyanosis in patients with TGA. It was soon to be overshadowed, albeit temporarily, by another atrial switch procedure described by Mustard et al. From Toronto in 1964. However, since the introduction of the double switch operation for patients with corrected transposition, C-TGA, it has been very important to learn the Senning technique. Surgical technique of modified Senning operation. The operation is performed during cardiopulmonary bypass, CBP, with variable degree of hypothermia depending upon the case profile. Steps: 1. Median sternotomy performed to expose the heart. 2. Thymus dissection is done. 3. Pericardium opened in the left side of midline, keeping extra length of pericardium to the right. 4. Extrapericardial dissection of both vena cava, superior vena cava, SVC, inferior vena cava, IVC performed. If IVC dissection is not able to perform due to unstable hemodynamics. 5. Systemic heparinization is done. Try to go on CBP with single SVC and two-stage right atrial cannulation till then. 6. Purse string sutures are placed in the ascending aorta for atrial cannulation and directly upon each vena cava for venous cannulation. 7. The vena cava purse string sutures are oval in order to maintain any effect toward narrowing of the vena cava when they are later tied. If the superior vena cava SVC is particularly small, the suture is used only to secure the cannula, and later, after removing the cannula, the caval opening is stitched directly with 7/0 polypropylene sutures. 8. Because the Senning operation is performed frequently and today, it is used to place marker stitches that will facilitate and speeden up the procedure. Placement of stay sutures. 2 ways. The stay stitches are placed on the superior margin of the right upper pulmonary vein, atrial junction, and the inferior margin of the right lower pulmonary vein, atrial junction, C to D. The other 2 stitches are placed in front of the crista terminalis, A to B. Points A and B are placed approximately 2 centimeters anteriorly from the interatrial groove. 1. Before CBP is established, record the circumferences of the SVC, IVC in millimeters. 2. Marking sutures are placed on the interatrial groove to define the cephalic point, C, and the caudal point, D, extent of the left atriotomy. 3. Marking 6/0. Proline suture, point B, is placed cephalad from the junction of the IVC and the right atrium at minimal distance of 15 millimeters, or which is equal to 2/3 of the circumference of the IVC. This point B defines the inferior extent of the right atrial incision. The crista terminalis, or terminal ridge, is a ridge of myocardium within the right atrium that extends along the posterolateral wall of the right atrium between the orifice of the superior vena cava to the orifice of the inferior vena cava, IVC. Lateral view of the right atrium showing the sulcus terminalis and Watterson's groove or Sundergaard's groove or interatrial groove in the figure. 9. While the patient's temperature is lowered to 24 degrees Celsius, ligatures are placed around each vena cava for later occlusion around each cannula. 10. If 2 venous cannulae are used, a small incision is made into the left atrium and a disposable sump-tick sucker, Medtronic ink, is placed into it. 11. Aorta is cross-clamped and a cold cardioplegic solution is infused, crystalloid or blood cardioplegia. Cardioplegia is repeated every 30 minutes and topical cooling with ice slush is also used. 12. The atrium is open between points A and B and the sum vent is placed through the patent foramen ovale, PFO, atrial septal defect, ASD, into the left atrium. First step, construction of atrial flap. Atrial flap is created from the limbic tissue anteriorly toward the superior and inferior aspects of each respective right pulmonary vein. This flap remains attached at the interatrial groove. Detach at the septal flap. When the septum is detached from the atrial wall superiorly, it is useful to press the forceps from between the SVC, aorta, and the right pulmonary artery toward the atrium to get a feel about the remaining thickness of the atrial wall. PFO or a small ASD can be closed directly. If a large ASD is present, the septal flap is reconstructed by suturing in a small piece of Gore-Tex patch material or the patient's pericardium. Alternatively, it is possible to make a cutback in the coronary sinus that will provide a second flap, which, sutured to the septal flap, will provide enough tissue. The coronary sinus cutback also enables us to construct a wider IVC channel. It is important to place the scissors deep into the coronary sinus or to place them over a pair of forceps. The cutback is then made into the coronary sinus with one single cut. Second step, construction of partial pulmonary venous pathway. The constructed atrial flap created by native atrial tissue along with autologous pericardial patch is later deflected into the left atrium. The first suture is placed between the left atrial appendage and the left pulmonary veins and through the septal flap. The suturing from the first suture is commenced on either side. The flap is to be sutured on the right side of surgeon, passes in the floor of the left atrium, LA, staying away from the mitral valve using 7/0 Prolene continuous sutures. The left side flap in respect to the surgeon is sutured within the left atrium to its origin at the SVC. These suture lines should diverge so as not to constrict the posterior pathway for left pulmonary venous return. Principle of suturing. The right flap and the left flap of this atrial flap can also be referred to as inferior border of flap and superior border of flap respectively. One arm of the double-ended suture attaches the flap superiorly, staying below the cut edge of the septum. The lower suture line runs towards the stay stitch below the right inferior pulmonary vein. This completes the floor of the SVC and IVC channel. Third step. Construction of the IVC pathway and SVC pathway. IVC pathway. The posterior base right atrial flap is sutured from the lower angle around the IVC. The caval pathway is completed anteriorly by stitching the caudal extent of the right side of the free right atrial wall to the atrial tissue about the IVC orifice and continuing to the coronary sinus. The coronary sinus is left to drain with pulmonary venous blood. If the coronary sinus has been incised, the coronary sinus blood drains within the systemic venous pathway. The suture line is placed posterior to the remaining rim of the coronary sinus to avoid injury to the atrioventricular node, AV. Construction of a wide IVC pathway is thus ensured by inserting a temporary short stent cut from a chest drain or piece of plastic tubing. SVC pathway. A second suture is used to complete the superior attachment around the SVC and along the limbic tissue. Both the IVC and SVC pathway flaps are sutured to the free edge of the anterior limb of the atrial septum, anterior mitral annulus, thereby redirecting the systemic venous return through the atrial septal defect to the mitral valve and left ventricle. Fourth step. Completion of the final pulmonary venous pathway. The perimeter of the left atriotomy is extended by incising onto the right superior pulmonary vein for a distance of about 1 cm. The pulmonary venous pathway is constructed by initially placing an interrupted 6/0 Prolene sutures from the appropriate point E on the free right atrial wall to the edge of the incision, point F, between the right pulmonary veins. Interrupted sutures attach the remaining segment of this flap to the rightward edge of the left atriotomy in order to complete the pulmonary venous pathway. Interrupted sutures theoretically should not restrict future growth in this area. Anterior-based RA flap was sutured to the in situ pericardium between the SVC and the IVC so as to make a pulmonary venous chamber, and this chamber was used to redirect the pulmonary venous return into the tricuspid valve, leaving the coronary sinus either in systemic venous confluence or pulmonary venous confluence. Caval snares are now released. Rewarming is started. Air is carefully evacuated from the heart via aortic needle vent. This vent is kept on low suction until we are ready to discontinue bypass.